Chairpersons, ladies and gentlemen, we have this after that exciting live case session, calcium modification session, and I'm going to cover today the calcium nodule. We know that calcium nodule is a different ball game, and management-wise, there is no guideline which tool is the best for debulking the calcium or managing the calcium. And how do we diagnose? On angiography, it may be very difficult to diagnose. Imaging is appropriate way to diagnose calcific nodule. Convex protrusion into the lumen, understandable. Irregular illuminal surface, which I will show you how it is seen on the imaging, and often significant calcium deposition proximal and distal to the lesion, which is seen as a sheet of calcium associated with, it's a thrombocalcific lesion. So what is the prevalence? Prevalence is about 5% in the autopsy and 8% on OCT imaging. And often it is seen in patients with CKD, type 2 diabetes, hypertension, advancing age, and post-CABG. So what are the specific areas where it can be seen? Most often in RCA and 20% in left main bifurcation. It's a motion during the cardiac cycle thought to be related to forming a calcific nodule in the artery. So tortuous arteries do have issues, and there the calcific nodule can prosper and become troublesome. So advancing age, as that we have covered already. So just to particularly highlight that you can see a before and after the bend, you can see a calcium sheet which is labeled there, and you can see a necrotic core. And then when heart contracts, that area particularly initiated the calcific nodule, which is at the bend. So about the 26 cases that have been highlighted, it's often seen in the tortuous artery, and necrotic core is there. It is predominantly, as I said, in RCA, and this is typically seen. So how will it be seen? This is an animated picture. We can understand there can be concentric calcium, eccentric or nodular calcium. And on imaging, the third picture is obviously the calcific nodule on OCT, and in IVUS fourth picture. But when we expand, we zoom this picture, OCT picture, we can see calcific nodule very well with those margins you can see are corrugated or jagged. That is where the thrombosis form. That's how it becomes atherothrombotic calcific lesion. And that's why it is difficult to manage. In IVUS, we can't identify because IVUS resolution is not that good, so we cannot identify what is there on the surface of the nodule, which was seen very well on OCT image. So what are the devices that we have applicable? We have balloon-based devices and we have atherectomy devices. And the new addition in atherectomy devices is, of course, laser and orbital atherectomy. And in the balloon IVL, we all know. So any of these tools can be used for management of the calcific nodule, but more often atherectomy is indicated. So if you go to see an algorithm which says that if eccentric lesion, which is nodular, is eccentric lesion, you can start with any of the balloons and you can ultimately decide atherectomy or no atherectomy. And you start with atherectomy and you have to go to the balloon. So it's a kind of dynamic use of devices which will decide practically on after use that which device will be better. So there is an algorithm which is discussed. Particularly, I am going to cover here the nodular algorithm, which says that if you have a nodule and if you confirm that it is a nodule on imaging, and if it is balloon crossable, you can use IVL. If not balloon crossable, then orbital atherectomy or rotational atherectomy is better. Rotational atherectomy requires a favorable wire bias. If the wire bias is not favorable, rotational atherectomy is not going to work because burr is not going to ablate the nodule. So in that orbital atherectomy, if the vessel is big, is most advisable. There are certain advantage and disadvantage. Once the lesion is debulked and you think it is on imaging, the calcium is cracked, then you can consider putting a DAS, then do a optimization with high pressure balloon, and the final imaging. This is the algorithm that is followed. Say suppose calcium is not cracked on imaging, then you can try ALCA in those particular subset of patients. So this is how algorithm has been currently existing, but there is no such fixed guideline. Be still a research area. So how do we identify whether calcium is cracked on imaging? You can see that on the post-atherectomy images on the top, there is reverberation that is seen, which indicates that calcium is cracked, light can pass through. So, and then you can deploy the stent and images are good. One side is rotablator, other side is orbital atherectomy. But sometimes you don't see that well the stent expanded, so you may see a asymmetrical expansion of the stent with a D-shaped, which is seen rarely, but results are not, long-term results are affected due to D-shaping of any of these post-stent due to calcium. So what are the challenges? It leads to higher thrombosis, higher ISR. Everything is higher, even for that matter, sudden death is known. Everything is higher in calcific nodule. So several mechanisms are purported. Stent under expansion, that is the most important cause, or asymmetrical or buckling of the stent. Stent malposition, which is very well known, fracture of the stent, repeated fracture of the stent, not immediately, but after some time stent is deployed, patient may present with ACS, and those patients may have a fractured stent. The edge dissection, because you use high pressure balloon, edge dissections are possible. Protrusion of the calcific nodule through the stent cell is also possible. And not only that, the de novo calcific nodule can be developed under the neointimal and previously deployed stent, neointimal hyperplasia. So there are, we know rotational atherectomy. Only thing that is to be remembered that when you use rotational atherectomy, you must do imaging, find out whether wire bias is favorable or unfavorable. If it is unfavorable, then rotational atherectomy is of no use. So then we can switch over to other modalities of atherectomy. So what are the other modality is orbital atherectomy. Advantage with orbital atherectomy that it can ablate both ways when you do the picking. And results are very good in large vessels. Stuck burr is almost unknown in this. Wire bias is very little, if at all it is there. So in a way, this technology is a good substitute in patients where rotational atherectomy is, but rotational atherectomy is very effective in the very tight lesion, calcific lesion, where nothing is passing. So next, if nothing is working, you can try IVL. Sometimes we have to try rotatripsy. So we can try IVL if the calcium cracking is not enough, and we can see that energy is delivered. It can cut deep and the superficial calcium. Once calcium is cracked, seen on the imaging, you can deploy the stent. It can fully expand. The most important thing is expansion of the stent. Now coming to the laser, we all know laser is a new technology. How it works is a very unique way of threefold action. And one is the light which breaks the molecular bond. Second, that is a sonic pulse which modifies the vessel compliance. And third is the bubble. The bubble which is very effective in debulking the morphology of the calcium. So this is the advantage with laser. And then of course, we are aware of these score flex and cutting balloon and opium. I have some experience with a very bad lesion at the origin of the LAD and crossing into left main. Classical nodule, very big one, very thick nodule. It was opened, I could not show that case here. I opened it only with the cutting balloon because it's so tight. It was not going to work anything else. Cutting balloon worked here. So there is no fear of if we compress the nodule, with the high balloon pressure that it will go on the other side. With the cutting balloon, it doesn't happen. Either it will cut or it will not be effective. So calcific nodules are like relatively rare, but they are not uncommon, and more commonly found in patients with diabetic that we have discussed. But the problem is post-intervention, everything mace rate, everything is high, but there is still a research required in this particular area to optimally manage the calcific nodule. Thank you very much for kind attention.